Okay, so if we ask Craig, now as I said, I haven't really worked with Craig before, so it's a really good one to assess and see how he moves. So Craig, I don't get too bogged down into where the feet are. You know, if his feet are really wide, I'll just say keep him shoulder width apart. You could get him to keep his feet together for standardized purposes. I'm more interested in just asking Craig to touch his toes and see how he reacts, what strategies he uses. So Craig, if you're all right just to touch your toes for me. Okay, good stuff. And then hold it there. And we can see we're getting quite a bit of retraction here with Craig. Okay, now back up again. And then once more, Craig, we're getting a bit of a posterior weight shift. We're getting a lot of retraction to the ribcage. So Craig's not the worst here. Where do you feel the tension there, Craig? Just through your hamstrings. Cool. And then back up again. So his hamstrings are decelerating the motion. Absolutely fine. Okay, we can get a little bit more range here, I reckon, with some of the exercises that we're going to do later on, and we could have him getting a little bit closer to his toes, which is, again, it's either here nor there unless it was relevant to his pain experience. So what you're going to find with a lot of patients, especially with back pain, is as they're about to touch their toes, and you ask them, when do you feel the pain? They're feeling the pain experience in the low back at the very start of the movement. Well, just what I've said there, ideally, we shouldn't be getting our back involved during the first bit of the movement, or a low back. Okay, a lot of the movement has to happen up here. So the more movement we get up here, the less we're going to have to do with our low back straight away. Okay, so I hope that kind of makes sense. So that's what we're looking for there with the toe touch. If I get Craig just to keep a proud chest, okay, and then touch your toes, Craig, just to kind of artificially, yeah, that's going to be an acute low back presentation that I would see a lot. Where do you feel that working, Craig?
Still kind of hamstrings, but I can feel that.
You feel your low back working. So again, that analogy to me would be Craig's trying to touch his toes with the tightened fist, so to speak. Okay, what we want to do is we want all them to let go. We want his abdominals, especially his internal obliques, to retract his rib cage, to get it back. And if I help Craig get his rib cage back here, okay, so if you touch your toes normal, Craig, and if I get his rib cage back, that's going to help him get down a little bit more. Okay, so when I do that, Craig, is there any difference?
I feel like I'm going a bit further.
Good, and then you just feel it at the hamstrings, is it?
Yeah.
Do you get anything in your back there?
No.
Good stuff. And then just to really re-emphasize the point, now I wouldn't do that in with a patient under any circumstance. I'm just getting the point across of the reaction that the rib cage can have. Now let's just check quickly with Craig. Let's get Craig to really help his diaphragm to lengthen and then recheck his movement. So Craig, take a breath in through your nose, keep your mouth closed. Now I want you to exhale for as long as you can. That's it, keep exhaling. Now I'm just going to help his rib cage to depress and retract. Keep going, keep exhaling, keep exhaling. Good stuff, keep exhaling. And now touch your toes for me. So we've helped his rib cage just to retract a little bit better, and we get a little bit more range. Is that a fair comment?
Yeah.
Okay, so again, this isn't trickery, it's not hocus pocus. It's just simply to show you that the more movement we get through that rib cage, the less he's going to have to work at his back, the less he's going to have to work at his hamstrings. Okay, so again, for learning purposes, I almost like to break this down into percentages. We get 25% of the work here, 25% of the work here, 25% of the work around the hips, 25% of the work around the hamstrings and the calves, decelerating that motion. Okay, so again, if one of them isn't doing its job, so if we take the 25% away from here, you're usually going to have 50% of the work happening at the low back. Okay, we perceive a threat, we get that movement error, whatever you want to call it, whatever movement models you follow, and then we have this conscious experience of either pain or discomfort or some sensation. So that's the toe touch, where again we really want to encourage that rib cage retraction to help the diaphragm to lengthen, to get the pelvic floor to actually contract, which will get a pelvic tilt, and then obviously we'll get the ilium to move over the femur. Now when Craig extends, what you're going to see a lot of patients, facet joint type symptoms with extension. So if Craig extends, and again I haven't looked at Craig moving yet through extension, good stuff, and then back again. Okay, and I'm just going to have a look at him here. So if you step forward, Craig, and then if you do it again, good stuff, and then back again, and then hands by your side and just lean back again slowly, good stuff. Do you feel any discomfort in your low back there? No. Good stuff, and Craig's not too bad here. Okay, so Craig, isn't the worst I've seen. Okay, so what I'm looking for here is the pelvis is going to go forward so that it can keep a center of gravity between his base of support. But what the key thing I'm looking for here, and I'm going to have to get Craig to slow it down a little bit here, which isn't ideal, but just to see, is I'm looking around the nipple line. Okay, so Craig, if you lean back again, okay, do we get height here? Do we gain height? And Craig doesn't look too bad. Do you feel a stretch through your stomach here? And then back again, okay? So why I want to see the nipple line increase is because I want to see ribcage elevation as Craig shifts his body weight forward onto his midfoot to forefoot. So as Craig extends, I want to see ribcage elevation, which is going to get anterior to pelvic tilt, which is going to help his hip as well, okay? So again, just like gait, as I step through, I want to see that innominate to go forward slightly, okay? Now, when Craig runs out of anterior pelvic tilt, what you'll usually see then is you'll see posterior, okay, pelvic tilt. So at the initiation of extension, we want to see that lengthening and that deceleration happen through his internal obliques, okay? So as his pelvis goes into anterior tilt, the internal obliques are going to lengthen to decelerate his body weight, rectus abdominis. The obliques that attach here at the upper rib cage, they're going to need to lengthen as well. If we can get that motion and these muscles can decelerate our body weight, then usually you're going to take that pinch off in the low back. What a lot of patients do, okay, what you're going to see a lot of patients do is when they lean back, they're going to lose height straight away. Okay, so Craig was able to elevate and come back a bit, whereas a lot of patients, they're just going to lose height straight away. So the nipple line doesn't actually gain height, it loses height, okay? And then I'm straight onto my back. I've got no deceleration through my abdominals. And again, if I lose height, you can see my abdominals are actually short here. What I want to see with extension is I want to see my abdominals decelerate my body weight. Because if they don't decelerate my body weight here, I'm going to fall over. Now, these movements in the mentorship, for me, are all about just managing your center of gravity between your base of support. Okay, so again, there's a lot of other things that influence this movement. It's not just the rib cage and pelvic floor and diaphragm. There can be a lot of stuff from all ankle injuries all the way up as well that we cover in the mentorship. But just for the sake of this course, I just want you to be very aware of the need for rib cage elevation as we extend. You restore rib cage elevation, then you'll very often get rid of that pinch in the lower back.